Welcome to the Health Headliner podcast by Tudu Digital. Our content is informational only and not medical advice. Please consult your provider. Now, let's dive into today's headlines.
If you stop what you're doing right now, just for a second, and sit in total silence, you might be able to hear it, or at least feel it.
Thump, thump.
It's the most primal rhythm of our existence. It's the very first sound of life, kicking in long before we're even born, and it's the last sound that marks our departure.
It really is the engine of the human experience.
You could almost call it the universal metronome.
Right. And because it's so constant, so reliable. I mean, it beats roughly 100,000 times a day, every single day, for decades. We just tend to tune it out.
We take it for granted.
We assume that as long as it's beating, the engine's running fine.
Exactly. We associate that heartbeat with vitality. If it's thumping, we're alive. But what if I told you that for millions of people, that rhythm is actually, well, it's broadcasting a distress signal.
A signal that is so subtle, so nuanced, that even the most trained human ears, we're talking doctors with decades of experience, are failing to hear it.
Until it's too late.
And that is the terrifying paradox of the heart. It can be working incredibly hard to hide its own failure. This is what we call the silent epidemic of heart valve disease.
And silent is absolutely the operative word here.
It really is.
When we say silent, we aren't exaggerating. The statistics we are looking at today are, frankly, staggering. We're diving into data that shows valvular heart disease affects more than half of everyone over the age of 65.
Just think about that for a moment.
If you're in a room with two people over 65, statistically, one of them has this issue.
That's a majority. It's not some rare condition. It's a normative part of aging, as common as gray hair, but, infinitely more dangerous.
And in the UK alone, which is where our source material is coming from today, there are an estimated 300,000 people walking around with severe aortic stenosis.
And here's the kicker.
A third of them have absolutely no idea. They are walking around, gardening, shopping, playing with their grandkids, completely unaware they have a mechanical time bomb in their chest.
That no idea part is the most dangerous part, because by the time you do have an idea, by the time you feel breathless or have chest pain or faint, the disease is already advanced.
And the prognosis for severe untreated valve disease, once those symptoms show up, is actually worse than many forms of cancer.
Much worse. We're talking about a risk of death as high as 80% within 2 years if it's not treated.
80%. That is a mortality rate that should be on the front page of every newspaper.
It is. It's a ticking clock where you can't see the face of the watch. You just don't know how much time is left.
But, and this is why we're here today, there's been a major breakthrough. We aren't just here to doom scroll through medical stats. We're looking at a brand new study released literally today, February 10th, 2026.
It's coming out of the University of Cambridge and Imperial College London, published in MPJ Cardiovascular Health.
And it promises a solution that, well, it sounds a little like science fiction.
It really does. It involves a superhuman listening device. Or, to be more accurate, a superhuman way of processing sound. A way to use artificial intelligence to hear the very things that doctors are missing.
To spot this disease years before it becomes fatal. So today on the Deep Dive, we're going to unpack this study. We're going to look at why the gold standard of heart diagnosis is too expensive for everyone, why the old standard, the stethoscope, is failing us, and how this new AI might just save thousands of lives.
It's a classic story of man versus machine, but with a twist. It isn't about the machine replacing the human.
It's about the machine giving the human a superpower.
Exactly. It's about augmented perception.
I love that term, augmented perception. So let's start with the problem, the why. Why are we missing these cases in the first place? I mean, I go to the doctor for my checkup. They put that cold metal disc on my chest, the stethoscope. They listen for a few seconds and say, sounds good.
And you leave feeling reassured.
And I leave feeling reassured. Are you telling me that reassurance might be false?
Often, yes, it is. And to understand why, we have to look at the reality of primary care today. This isn't about bashing doctors. It's about the system. Think about your average appointment with a general practitioner, a GP.
It's quick, maybe 10 minutes if I'm lucky. Usually feels like 5.
Exactly, 10 minutes. In that time, the doctor has to greet you, update your file, ask about your symptoms, check your blood pressure, maybe discuss your medication, ask about lifestyle, and get you out the door.
So the actual physical exam.
The part where they listen to your heart is a tiny fraction of that. 30 seconds, maybe?
It's a pit stop. It's a check-the-box moment.
It is. And Professor Anurag Agarwal, who led this research, points out something crucial. Cardiac auscultation.
Which is just the fancy medical term for listening to the heart.
Right. It's a really, really difficult skill.
I assume it's like learning a language or an instrument. You have to tune your ear. You have to know what to listen for.
Yeah. You absolutely do. And like any skill, if you don't practice it with intent, it degrades. Professor Agrawal notes that this skill is declining. We rely so much more on technology now, blood tests, scans, that the art of listening is fading.
And then there's the environment itself.
Yes. A doctor's office is not a sound studio.
Form it.
GP surgeries are noisy. You've got people in the waiting room, phones ringing, traffic outside, the hum of the computer, the rustle of your clothes, trying to hear a soft murmur from a heart valve that's just starting to fail.
It's like trying to hear a whisper in a thunderstorm.
That's a great analogy. And the numbers, they really back this up. The study mentions the sensitivity of a standard GP practice using a stethoscope.
This is the stat that really jumped out at me. The sensitivity can be as low as 45%.
Let that just sink in for a second.
That's
45%.
That is less than a coin flip. I could flip a coin and have a better chance of being diagnosed correctly than having a doctor listen to my chest in some of these cases.
Essentially, yes. If you walk into that clinic with heart valve disease, there's a slightly better than even chance that the doctor will say your heart sounds completely normal.
So for every 100 people with a sick heart, 55 of them walk out the door thinking they're fine.
That's the terrifying part. It just completely undermines the confidence we place in that annual checkup.
And again, it's not because the doctors are bad at their jobs.
No, not at all. It's because the tool, the human ear, combined with a standard stethoscope in a noisy room, has reached its physical limit. It just isn't sensitive enough to catch the disease early.
And early is when we want to catch it. We don't want to wait until you're collapsing.
Right. So we're in this situation where the cheap, easy test, stethoscope, misses half the cases. But we know there's a better test, don't we? The echocardiogram.
The gold standard.
Exactly. It uses ultrasound to literally look inside the heart. You can see the valves opening and closing in real time. You can measure blood flow. You can see the turbulence. It's definitive. There's no guessing.
Okay, so here's the obvious question then. If we have a definitive test, why don't we just give everyone an echo? Why mess around with stethoscopes at all?
It comes down to money and time, the two currencies of healthcare. An echo requires a highly trained specialist, a sonographer or a cardiologist. It requires very expensive machinery, and it takes about 30 to 45 minutes for each patient.
So if you tried to screen everyone over 65,
the system would collapse instantly. The NHS, or really any health system in the world, simply cannot afford to give an echo to every single person over 65 every year. The waiting lists are already months long, just for the people we know have problems.
So we're stuck. We're in a bind. We can't screen everyone with the perfect tool because it's too expensive, and the cheap tool we use for screening is missing half the people.
That's the clinical bottleneck. Yeah. That is the exact gap this new study is trying to bridge. We need a tool that's as cheap and fast as a stethoscope, but as accurate, or nearly as accurate as an echo.
And that brings us to the study itself. From Cambridge and Imperial, this wasn't some small project in a lab, was it?
No, this was a massive undertaking, a multi-center study involving 5 different NHS trusts. They recruited 1,767 patients.
In the world of medical audio data, that is huge.
It's one of the largest data sets of its kind ever collected. And what's important is who these patients were. They didn't just pick healthy 20-year-olds. They picked people who were already going in for an echocardiogram. So you had a mix of healthy hearts, slightly sick hearts, and very sick hearts.
A representative slice of the real world?
Precisely. So for each of these nearly 1,800 people, they did 2 things. First, they record their heart sounds with a digital stethoscope.
Which looks pretty much like a normal one.
Looks the same, but it has a microphone and Bluetooth. And second, they do the full gold standard echocardiogram. So they have the sound, the cheap test, and the image, the expensive test, for every single person.
And this brings us to what you called the secret sauce, the methodology, because they did something really counterintuitive here.
They did. This is where it gets fascinating for anyone interested in AI. Usually when you train an AI for a medical task, you train it to mimic a doctor.
Right. You'd say, here's a recording. Dr. Smith says it's a murmur. Computer, learn to identify that.
That's called supervised learning with human labels. You get a panel of expert cardiologists to listen and label recordings. This one have a murmur. This one is clear. Then you teach the AI to match the human labels.
But they didn't do that.
No. They realized there's a fundamental flaw in that logic. If the humans are missing 45% of the cases, if the humans are the weak link, and you train the AI to mimic the humans, what are you really doing?
You're baking human error into the code.
Yeah.
You're automating the mistake.
Exactly. You're teaching the AI to make the same mistakes that doctors make. You're creating a digital version of a flawed human ear.
That's such a crucial insight. If the teacher is flawed, the student will be flawed.
Precisely. So they bypassed the human ears entirely. They fed the AI the digital sound recordings, but for the answer key for the label, they gave it the raw data from the echocardiogram.
So they told the AI, don't listen for what a human thinks is a murmur. Listen for the sound of a heart that the ultrasound says is broken.
Yes. They grounded the AI in the physiological truth, not the human interpretation. And this changes everything, because now the AI isn't limited by what a human ear considers a murmur.
They can start finding patterns in the audio that are completely inaudible to us, these subtle acoustic features.
Exactly. I mean, let's talk physics for a second. When a heart valve is narrowed, that's stenosis, the blood has to squeeze through a smaller hole. That creates turbulence. Turbulence creates noise. But maybe there are other sounds. Maybe there's a tiny frequency shift or a change in the texture of the sound that our brains just filter out as background noise.
But the AI doesn't have those biological filters. It just sees the raw data.
It sees the raw waveform, and it correlates everything in that waveform with the echo result. It might find that a certain sub-bass frequency combined with a specific rhythm is a 100% predictor of valve disease, even if a human doctor can't hear it at all.
That's fascinating. It's like teaching a computer to predict rain, not by looking at whether a human thinks it looks cloudy, but by analyzing the humidity and pressure sensors directly.
That is a perfect analogy. You are going to the sourced data. Sure. And because of this training method, the results were, well, they were dramatic.
All right, let's get to the showdown. Part 3. They put this algorithm to the test. And they didn't just test it on a computer. They pitted it against actual human doctors.
They did. They took a test set of patients, people the AI had never heard before, and asked the AI to diagnose them. Then they asked 14 real-world GPs to listen to the same recordings and make a diagnosis.
And these GPs weren't just interns, right? A full range of experience.
Full range. From brand new doctors with 0 years of post-qualification experience all the way up to veterans with 28 years on the job. A really fair representation of who you might see at a clinic.
And the headline numbers for the AI.
Let's break it down by disease. For severe aortic stenosis, that's the narrowing of the main valve leaving the heart, the AI identified 98% of the patients.
98%. That's basically perfect. A virtual safety net.
Incredibly high. And for severe mitral regurgitation, that's when the other main valve leaks backward, it caught 94%.
And just to remind everyone, severe means these are the people who need surgery now.
Yes. These are not watch and wait cases. These are the people with that time bomb in their chest. Catching 98% of them it's massive.
So how did the humans do?
The humans struggled. The study showed that the AI outperformed every single GP.
Every single one, even the doctor with 28 years of experience.
Every single one. And the issue wasn't just that the GPs were worse in general. It was that they were wildly inconsistent.
What do you mean inconsistent?
The study notes that some GPs had high sensitivity, meaning they referred almost everyone just to be safe. I think I hear something, better check it. But that just floods the system with false alarms.
And the others?
Others had high specificity, meaning they only referred the ones they were absolutely sure about. But that means they missed actual sick people.
It's that variability that's so dangerous in a healthcare system. You don't want your survival to depend on whether you got the cautious doctor or the confident doctor.
Exactly. You want a standard of care. You want reliability. And that is what the AI provided. Consistent, high-accuracy results every single time.
So hearing this, the natural reaction is to think, okay, fire the doctors, hire the robots. But, we always have to pump the brakes on the hype train on this show.
We do. And the paper is very honest about this. There are limitations. This isn't a magic wand. It's a tool. And like any tool, it has blind spots.
Okay, so let's talk about where the AI stumbled. It wasn't perfect across the board.
No, it wasn't. We've been talking about severe disease. But there's also moderate disease. This is where the valve is damaged, but maybe not critically. Yeah.
And the AI had a harder time with that.
A significantly harder time. For moderate mitral regurgitation, the sensitivity dropped to 75%. And in some of the training data, it was as low as 50%.
Why the drop-off? Why is moderate so much harder to hear than severe?
It's physics again. Severe disease creates a lot of turbulence, which makes a loud noise, a loud murmur. Moderate disease creates less turbulence. The sound is just quieter.
It's the difference between a rushing river and a trickling stream.
Exactly. And the AI, despite its superhuman training, is still relying on sound. If the sound is too faint or if it's buried in the other noises of the body, it struggles.
But how much does that matter? I mean, if it misses moderate disease, is that a critical failure?
The experts would argue that missing moderate disease isn't as catastrophic as missing severe disease. If you have moderate disease, you probably need monitoring, not surgery today. Missing a severe case is life-threatening.
Still, it's something they'll need to improve.
Absolutely. For a screening tool to be truly revolutionary, we'd want to see those numbers come up. We want to catch people before they get severe.
There was another limitation mentioned about how the GPs were tested. We said the AI beat them, but the fight wasn't exactly fair.
Right. The GPs were listening to recordings through headphones. They weren't in the room with the patient.
Does that really matter? Sound to sound right.
Not quite. When a doctor listens to your chest, they aren't just listening. They're moving the stethoscope around. They might ask you to lean forward, to hold your breath, to stop the lung noise. They're using tactile feedback. They're looking at you, seeing if you look breathless.
There are context clues.
Exactly. And by stripping all that away and just giving them the audio file, you're handicapping the human a little bit. The authors acknowledge this. They say, look, this might have lowered the GP performance, but, and this is a big but, the gap in performance was so wide that it's clear the AI is picking up things the humans just aren't. Even if the doctors had been in the room, it's highly unlikely they would have reached 98% sensitivity.
It wasn't a close race decided by the headphones. It was a blowout.
It was a blowout on consistency alone.
There's one more big limitation we need to touch on, which is population bias. The study used people who were already at the hospital for a reason.
This is a classic issue in medical studies. It's called spectrum bias. If you go to a heart valve clinic to test your device, you're in a target-rich environment. Maybe half the people there have a problem.
But if you go out and screen the general public...
Maybe 5% do, or 2%.
And why does that matter for the AI?
It affects the false alarm rate. If you test a general population where almost everyone is healthy, even a small false positive rate can become a big problem. If the AI has a 10% false positive rate and you test 1,000 healthy people, you've just sent 100 healthy people for a needless echo.
Which clogs the system all over again.
Exactly. So the study notes that before this is rolled out to every GP in the country, it needs to be tested on a general asymptomatic population just to make sure it doesn't cause a different kind of bottleneck.
Which makes total sense. So let's imagine the future. Let's say this tech matures, it passes those trials. What does a visit to the doctor look like in, say, 2030?
It looks much more streamlined. The paper outlines what they call a super filter concept.
A super filter, how does it work?
Okay, so you walk in for your annual checkup. You're 68 years old. Before you even see the doctor, the nurse or a medical assistant does the vitals, blood pressure, temperature, and then they take a digital stethoscope, place it on your chest for 15 seconds.
That's it, 15 seconds.
That's all the AI needs. It records the sound, uploads it, processes it, and gives a binary output. Refer for echo, or all clear.
Green light, red light.
As simple as that. If it's green, you go home knowing with 98% certainty you don't have severe disease. If it's red, you get put on the list for an echo.
And because we filtered out the 90-some% of people who were fine, the waiting list for that echo drops from months to days.
That's the dream. It's about resource management. As Professor Agrawal said, if you can roll out people who definitely don't have significant disease, you can focus resources on those who need them most.
It stops the worried well from clogging up the system.
And ensures the silent sick get seen immediately. And economically, this is huge. Treating heart failure is incredibly expensive. Fixing a valve before the heart fails is much cheaper and infinitely better for the patient.
It's preventative maintenance for the human engine.
Precisely.
So as we wrap this up, what I'm really struck by is how this is a perfect example of AI doing what it does best. It's not writing poetry or falling in love. It's just looking at massive amounts of noisy data and finding the signal.
It's pattern recognition at its most powerful. And our bodies are just big bags of biological patterns.
We usually think of AI as artificial intelligence, but I really like that reframing we touched on earlier, augmented perception.
That's the key takeaway, I think. If an AI can hear the blood moving inside your heart better than a human can, what else can it hear?
Can it hear the early signs of Parkinson's in our voice? Can it hear the micro movements of a stroke in our gait? What other silent signals is our body broadcasting that we just haven't built the right microphone for yet?
That is the frontier. We're moving from reactive medicine treating symptoms when they appear to predictive medicine, reading the signals before the damage is done.
And that shift is going to save an incredible number of lives.
It absolutely will.
So to everyone listening, if you take one thing away from today, it's this. The stethoscope is finally getting an upgrade. And silence isn't always golden.
Sometimes it's just something we can't hear yet, so check your heart.
Check your heart, and we will catch you on the next deep dive.
Thanks for tuning in to the Health Headliner podcast by To Digital. Like and subscribe for more health news and breakthroughs. Stay healthy and informed. See you next time.